make a short presentation about COPD and heart failure. So most of us know what COPD is, and so it's a combination of emphysema/asthma with some reversible component. If you look at it, it is the fourth largest commonest cause of death, and it's a rising prevalence, and at least in the developing countries, before we see a decrease in smoking, we will see an increase in smoking related illnesses, and this is number one. So most of us in our lifetime will be dealing with a lot of COPD and a lot of heart failure. If you look at what happens to these patients with COPD, about a third sort of die because of heart problems, about a third die because of cancer, and a third die because of just poor lung function. If you look at it from a heart failure provider's perspective, from a cardiologist's perspective, most patients with heart failure will have some sort of dyspnea, and if you were to tease out how much of these patients have COPD that's prevalent, it's somewhere in the range of 20 to 32% of patients who have COPD. The risk of developing heart failure in COPD patients is greatly increased, and it's about 4.5 times, and this is obviously because of the same predisposing factors such as tobacco use, etc. If you look at various studies that have been done, the prevalence goes anywhere from as low as 15% to as high as 52% prevalence of COPD in patients with heart failure. If you look at current newer studies, and I would say newer meaning just 10 years old or less, the amount of focus that we have on looking at ejection fraction is much higher compared to the focus that we have in terms of pulmonary testing, and rightly so, because when you're looking at a cardiology perspective, you don't want to test pulmonary functions in the hospital when the patient has pulmonary edema and may not have an accurate testing. If you look at the prevalence of COPD in heart failure patients, the mortality of these patients can be as high as 70% over a 5-year period, and they can, if not properly managed, can increase the risk of decompensations. I'm just going to skip over some of these things because we've discussed this in previous lectures or coming up, but I'll just talk about malnutrition, and there is a lot of importance of malnutrition in these patients because they're also on steroids, and steroids cause a decrease in type 2 fibers and a relative increase in type 1 fibers. So it's important to recognize steroid myopathy in these patients as well. Again, a lot of focus has been on TNF-alpha, and these are common mechanisms in almost all chronic disease states. Let's move forward talking about how heart failure can cause increased lung stiffness and bronchial congestion, and hence some amount of edema. Dyspnea. So it's important to remember that increased left atrial pressure can cause post-capillary pulmonary hypertension, and that causes increased lung stiffness and altered numbers when you do lung function testing. And as we look at COPD and heart failure, this happens to me all the time if I'm taking a call from the emergency room. Oh, I have a patient with shortness of breath, has a history of COPD, has a history of heart failure, and is coming in with shortness of breath. Can you just admit the patient? Now, the number one cause for admissions to the hospital in the United States today is heart failure. It is the number one DRG, which means the number one diagnosis-related group that comes or gets discharged from the hospital. So we're extremely busy, and if a COPD exacerbation is causing the patient to come in, obviously I'm not going to be able to treat that patient. So it's important that I know whether it's really COPD or whether it's heart failure. So what are the things that could help or not help? And it's important to say, okay, what does the X-ray look like? Is it red? Or is it just hyperinflation? And sometimes it helps, sometimes it doesn't. Every once in a while, they will come up with BNP, and BNPs can help, but not necessarily all the time. And here is a simple algorithm that most of us are used to using, where a BNP less than 100 will most likely help you in excluding heart failure as an etiology. And then if it's greater than 100, then depending on the clinical situation, one could evaluate further. How do you treat COPD in the context of heart failure? So it's important to talk about smoking cessation, and it's important to know that even during the hospitalization, you can start nicotine replacement therapy. It's safe, it's effective. If it works for the patient, it would do them a lot of good. You can also use other therapies that have been proven for smoking cessation. They're okay to be used in heart failure. You should think about cardiac rehab or pulmonary rehab depending on where you live. It can get paid for or not. And important to think about vaccinating these patients against things that could kill them. So influenza and pneumococcal vaccines are important to be thinking about. Supplemental oxygen, it's important. In the US, there are certain guidelines that we have to follow when we want to give oxygen for patients who have low oxygenation status. In general, these are based on evidence, and the evidence is that if you have a resting pulse oximetry of less than 90 is when you should start thinking about supplementing oxygen. Screening for other things, we talked about anemia, sleep disorder, breathing, depression, because it does coexist all the time. What about ACE inhibitors when you have COPD and heart failure? They're good, you should be using them. What about beta blockers? So the selective beta blockers are decidedly better than the non-selective beta blockers. So if you were thinking of metoprolol, it has a 20-fold more affinity for the beta-1 receptors, and especially in COPD, it's fairly well tolerated, and it does not decrease the bronchodilation. So in clinical practice, we do use in severe COPD, when a patient is actually wheezing, try to do metoprolol rather than carvedilol. But the big data doesn't exist in terms of long-term outcomes in either one of those cases. If you look at cardiology studies, single center, a couple of centers, there is evidence to suggest that if the patient is not actively wheezing, you should be using beta blockers in this group, and they're fairly well tolerated and outcomes are better, and we'll talk about it in a second. If you look at inhaled beta-2 agonists, again, data does not exist whether you should use combination therapy or not in terms of beta agonists and beta antagonists. But most of us do use them together. If you look at anticholinergic medications, These agents have been known to reduce COPD exacerbation and improve the dyspnea. However, outcomes are not there. The data just doesn't exist in terms of outcomes for cardiovascular events. If you look at beta-2 agonists, you can have worsening of arrhythmias, you can have downregulation of the beta-2 receptors, you can have hyperkalemia. But if you look at studies, again, no large big studies have been done, but whatever we have shows that you can give salmeterol or salmeterol plus fluticasone, and the events are not worse. If you look at the heart failure management programs that have used again, you can safely use beta blockers in this patient population. Again, the cardiovascular effects of fluticasone and salmeterol have not been investigated. Most of us do use it on a long-term basis, and you just monitor the patient. Generally, things such as theophylline and the roflumilast are not useful. They have shown to be bad for these heart failure patients. So if you have a COPD patient on these medications, you should try to avoid them or switch them out to something that's better. In terms of surgery for heart failure patients, I do about 30 cardiac transplants a year, about 70-75 LVADs a year. It always comes up, okay, how bad are the lungs, or the patient's going to get through these surgeries or not. And we look at PFTs, most of these patients have altered PFTs. So we use the criteria, which is the GOLD criteria, and as long as GOLD criteria 1 and 2 patients, which is an FEV1 of greater than 50%, most of these patients do well. Most of them have issues with restrictive because of pericardial and pleural effusions and just boggy and stiff lungs. And they do get better once you replace the heart or you put in an LVAD. So the big scheme of things, as long as you have FEV1 greater than 50%, you can get them through surgery. So that's my end of my talk for COPD and heart failure.
Thank you very much. Any question? Regarding the possible arrhythmogenic effect of beta-2 inhalants, are there data, or I know that it's scanty, data, is there any reason to prefer, say, the anticholinergic over the beta-2 stimulators, or to use cortisone paths rather than stimulators?
So if you look at the lung literature, there is some evidence talking about coronary artery patients not doing well with the beta-2 stimulants. In the heart failure group, it has really not come through when we talk about overall increase in arrhythmias or so. Generally speaking, in the hospital, post-operatively, we see patients wheezing quite a bit, and we use a lot of beta agonists, which end up putting them into atrial fibrillation and so on and so forth. But I would assume that carries on. So if you can avoid a beta-2 agonist using a combination of a steroid, that's general practice. But again, no guideline recommendations, no large randomized control trials. This is just regular practice based on just personal perceptions.
Yes.
very excellent presentation. Do these people benefit from ambulatory oxygen? I think that they carry on their back.
I'm sorry? Can you say that again?
COPD patients, like the one you talked about, do they benefit from ambulatory oxygen?
Yes. If
Does it help them in walking around with a cylinder on the back?
Most of them don't have a cylinder on their back. They have where I work, they have a little ruler thing that they can carry. These days, they have a small plastic canister, also which with much more compressed air if they're walking around. So the technology is such that they don't have to carry the cylinder on their back, but it does help. Yes.
It does help.
Yes.
So if there are no further questions, thank you very much. And we have ended this session just on time. And
do you want me to just do a 5 minutes?
I mean, if you can do it in
5 minutes.
Okay, if you do it in 5 minutes, that would be great.
Awesome.
Yes. Okay.
Can we have a show of hands if people want to wait and
No,
listen?
if you can maybe, yeah. Yes.
Okay, let's go for it. Anemia is very prevalent in heart failure. The definition of anemia by WHO looks at less than 13 for men and less than 12 for women. And if you look at it in cardiovascular populations, it's about 9% of adults having overall anemia. If you look at heart failure, the anemia worsens with worsening NYHA class. So worsening heart failure, the higher prevalence of anemia. So this has been noted in many studies. If you look at various prevalence in different studies over a period of years, you can see as low as 14% and as high as 70% prevalence of anemia in heart failure populations. So it's there, it's ubiquitous, you can't miss it. If you look at patients in the WALHEFT database, and this has been extensively churned, and we'll see this over and over again, you can see that patients with anemia versus patients without anemia, these patients have worse heart failure. They have a higher NYHA class, they have more shortness of breath, they have more edema, and they have higher CRP and BNPs. There's various reasons in terms of why you should have anemia and heart failure, but it could be because of decreased cardiac output, impaired renal perfusion, cytokines, iron deficiency because of malabsorption, ACE inhibitors, dilutional, and so on and so forth. Why does it happen? It's been postulated that it's a reaction of the body to combat heart failure. So it produces a reduction in the systemic vascular resistance, increase in cardiac output by increases in heart rate and stroke volume, and hence it's a response. But then as the response goes on over a period of years, it becomes pathological, causes left ventricular hypertrophy, ischemic burden increases, and mortality gets worse. So it becomes from a physiological state to a pathological state. In a patient with heart failure, with bad myocardium, it could be deleterious and probably fatal down the road. Various people have suggested various mechanisms in terms of how to tie it all together, and but the bottom line is there is a definite relationship between decrease in hemoglobin to an increase in mortality. So when you look at independent factors, anemia was singled out as an independent factor. Erythropoietin levels are also implicated, and if you look at the study done here, they looked at erythropoietin levels and hemoglobin levels, and they correlated either directly or inversely to mortality. So if you look at this is almost like a J-shaped curve where once the hemoglobin dips, your mortality increases, and then with polycythemia, your mortality starts increasing again. So, how do we treat anemia? In terms of transfusion, there is very little evidence that transfusion does anything for these patients. In patients who are not symptomatic, we recommend that we use a conservative strategy where you don't transfuse unless the hemoglobin is less than 8. Again, no large randomized data is there at all. In terms of correcting anemia with erythropoietin-like agents, initial studies showed some promise, and the biggest large powered randomized double-blind control study was done in actually many countries, and the bottom line was that it did not show any real effect in terms of outcomes. It did cause higher thromboembolic events and higher thrombotic events. So, in the big scheme of things, most groups and guidelines suggest not to use erythropoietin for treatment of anemia in heart failure. If you look at iron and iron deficiency, there is a definite incidence of iron deficiency anemia in patients with heart failure. There have been various mechanisms, and there was a trial that looked at intravenous therapy, and it showed an increase in patients' exercise tolerance, and symptoms were decreased. There were no long-term mechanistic or outcome based on mortality that have been tested, so this is not yet a full recommendation. But if you have a patient who does not respond to oral iron therapy and has iron deficiency anemia and has heart failure, one can use intravenous iron without deleterious effects. Conclusion, anemia is there, it's present in heart failure patients, it's bad. It is associated with higher and worse outcomes, but we don't have any therapies that can change that. Thank you.